Good afternoon, ladies and gentlemen. Can I ask everyone to go on to mute, please? That would be wonderful. Just before we start today's meeting, I just wanted to put on record. We lost a real friend of the Trust last week in Charles Hart, who was Deputy Chairman of the Patient Forum. Charles joined the Patient Forum, I think, in 2011 and did quite extraordinary work as a volunteer. And I would just like to thank him and his family for his years of service. Charles passed whilst being with us on the Fairfax board last week. And again, I'd just like to thank our staff, who I know provide phenomenal care to those people at end of life when they're with us. Charles, thank you again. You were an example to us all, and I would encourage any members of the public, and I know we've got some of our wonderful governors with us today, to volunteer. Volunteering into the NHS is wonderfully fulfilling, and you can make a real impact on the patient's experience and the work we do for citizens. In terms of apologies for absence, the only one I'm aware of is Richard Coffey, who is abroad, and we hope that Bhaskar will be able to join us at some point, but it's great to have Charles with us. So any new declarations of interest, apart from the fact our new Managing Director, Adam Carson, is in position this week, but any new declarations of interest, please raise a digital hand. I can't see any digital hands raised, so thank you. Now, the last set of minutes held on the 1st of March. If you had any points of accuracy on those, could you please raise a digital hand? I can't see a digital hand raised, so I'll take those as accurate. And then in terms of these action points arising, I think there's only one on page 21 of our pack, which was regarding the percentage increase in staff from 2020 be included in the Chief People Officer's report. That was provided to me by email. Thank you, Gertie, but if we can make that visible to colleagues and members of the public, that would be wonderful. Got quite a lot of things to cover today as we start our new financial year. I'll take the integrated care partnership report as read, as I gave a verbal update last time. But the one thing I would just reiterate is I have invited Chris Baines, Chairman of Health Watch, to come and regularly speak to the Board of Directors to give us feedback on how our citizens are feeling about the health services we and partners and stakeholders provide. And Chris has kindly accepted enthusiastically that invitation. So we will keep you briefed on how that goes. Any questions, though, on that part of the report? Okay, so we move on then to some items for approval. We have had our board workshop this morning, so members of the public are aware, which included a very sad patient story about an experience with the system and with us from a family member. Some learnings for us there. We had a good session on the staff survey, and we also talked about the financial plan, which we now come up for approval for next year. So members of the public can be assured this has been fully discussed already by the Board of Directors. So Kim, what would you like to emphasise?
Thank you, Chair. As I said, this is the final version of the annual plan. I took a draft version of this plan to our confidential board last time, so we have spent quite a bit of time talking about it as a board. And indeed, we had further discussions this morning. Key things that I just wanted to highlight is that we are presenting a balanced plan with a £20 million cost improvement and productivity target. within, and that's within the context of a system deficit plan of 48 million pounds. I thought it was useful just to point that out to board members. That draft plan from a system perspective is yet to be formally accepted, so that there may be further revisions, particularly looking at some of the other providers within this system around changing their submission. But from our perspective, we have submitted a balanced plan. It is a challenging plan for us in terms of a £20 million CRP programme. We had in-depth discussions this morning about how we've got things in place in order to deliver ensure that we deliver the savings and efficiencies and productivity opportunities available to us as an organisation. We have got the Excel in Everything board set up, and we've had a couple of meetings and now to progress those transformative schemes as well as some of those productivity schemes. Three key things that we need to focus on as an organisation moving forward is around the recurrent delivery of our Excel in Everything programme. We need to reduce our agency staff in order to ensure that we improve the quality of the care that we provide as well, and also increase our productivity to deliver on our elective activity, which will also reduce wait times for our patients. Those are the key things that I wanted to bring out, and also for the board to note the risks and assumptions that are listed on page 5.
Okay, thank you, Kim, and thank you all colleagues. I know what's been an awful lot of hard work gone on in the background to get us to a break-even plan for next year. A couple of things I want to say in a wee while, but questions and perspectives, Glenn?
Yeah, thanks, Kim, for the work you put into this. Just to emphasise a couple of points in there, really. I mean, firstly, it is a tough ask to deliver the level of cost improvement that we're planning to over the coming year, but we're determined to do so. Obviously, we firstly to maintain our record of not having gone into deficit, which is well over a decade of not being in that position, which we should be very proud of. But it does put a bit of pressure on us. But the discussions I've had with the ICS chief executive are that if we can deliver a break-even plan, then that will free us up from the scrutiny that's going to take place across the system around some of the deficits that are elsewhere in the system. And whilst I'm very open to being scrutinised, what I'm also keen to do is to ensure that our managers, our leaders have time to deliver the things that are in this plan, so that hopefully allows them all to concentrate on the components that are in there. And what we've obviously tried to do through the plan is to link quality improvements with cost improvements, particularly moving away from agency costs and substantive employment of staff, and continuing our good record of productivity improvement and doing the amount of elective work that we can do to generate additional income. So those will be things that we can concentrate on. So that's why we're putting together this tougher plan than I've seen in a number of years, but I think it is deliverable.
Thank you, Glenn. Any other questions or perspectives? We are now obligated to talk about things within a system context, and thank you for doing that, Kim, but I think it's just worth for members of the public to be aware. So in 22-23, we delivered a break-even actual in the year we've just finished. We're saying next year we will deliver again a break-even. The George Eliot made a small, effectively break-even plan in 22-23. They're going from that to minus 7.75. UHCW this last year lost about 14 million, and they're going to a loss of 42 million. So they're the sort of numbers, and CWPT are budgeting for a small surplus next year. So that's the way the system is made up, and that's why there's still some scrutiny, I think, on the system numbers. So thank you, Kim. If you're not happy to approve the financial plan for next year, despite the challenges that Kim and Glenn have laid out and we talked about this morning, please raise a digital hand. Okay, super, duly approved. Then we'll move on to the annual capital programme for next year. Sophie.
Thank you. So the paper goes through the projects that are almost halfway through, so need to be completed, and some requests, recommendations to board to approve sign off on some of the capital funds. The same as normal years, Kim is still having ongoing conversations with the system around our capital allocations. So we're unable to finalise our whole capital programme. However, what's really important, and the feedback that we've had from our teams, is it's really important that month one we give them a green light on some things so that we don't put the pressure on ourselves as we move forward. And the board will be aware we've got a really ambitious capital programme anyway this year, so the more we can do to help them do that, the better. So what we've done in this paper is say the things that we're asking the board to sign off today that we move ahead with, and also highlight to the board the projects that we would like to do if we were able to secure those funds through the ongoing discussions that Kim is doing. My suggestion on that is that we bring it back when we have finalised that, so that the board are aware of the risks if we are unable to do some of those projects. Many of you will see things like maternity theatres, fluoroscopy, they're real risks to our organisation. So if we aren't able to secure the funds, we may need to have a different conversation and just understand that. So here really for sign off on the things we can go ahead with and highlighting what we would like to go ahead with, and we'll bring that back when we can with Kim.
Thank you, Sophie. A really exciting year of laying down long-term assets of the trust. We know there's a phenomenal amount of work that's going on behind the scenes to make this a reality. We are conscious, and I think it's in some of the questions a bit later for members of the public and governors, that it does cause some practical issues in terms of car parking, signage, etc. But it's absolutely the right thing for us to be getting on and doing at pace for the citizens that we serve. Any questions or perspectives from colleagues? Again, we've talked about this in board workshops. Thank you, Sophie. So if you're not happy to approve, could you please raise a digital hand? Duly approved. Thank you very much. So we then move on to the Foundation Trust Code of Governance review. Thank you, Sarah, for all the work you do behind the scenes on this and the various different terms of reference. What would you like to pull out on this?
Yeah, just to highlight, this report outlines the trust compliance against the SWFT Code of Governance following my review, and I'm asking the board if they can confirm its support for the FT Code of Governance and declare compliance against all provisions of the code, which will be outlined in the Trust's 22-23 annual report. Thank you.
Okay, thank you, Sarah. Any questions on the Code of Governance review? Okay, if you're not happy to approve, please raise the digital hand. Thank you, Sarah. Thank you, colleagues. And then the annual review of committee terms of reference. Back with you, Sarah.
Thank you. So each of the committees have considered their terms of reference as part of the annual review process, and the proposed amendments are shown as track changes for the board's consideration and ratification, please.
Nothing substantive has changed, though, has it, Sarah?
No, they're all minor points, Russell.
And all of the chairs of the subcommittees have gone through those in the subcommittees, haven't they? Super. So any questions from colleagues? Again, if you're not happy to approve, please raise a digital hand. Duly approved. Thank you. Then the annual review of Register of Directors interests and non-executive director independence review. Bit of a mouthful. Again, back with you, Sarah.
Thank you. So the updates are shown as bold and strike through. All directors have updated their declarations of interest as part of the annual review process, and all non-exec directors have confirmed their independent status, which will be declared in the Trust's annual report. So the report's to be formally received and noted, and to agree the independent status of the non-exec directors. Thank you.
Thank you, Sarah. Any questions from colleagues who have obviously seen that and filled out the relevant bit? The only thing I would say to colleagues is I have become aware in other organisations of colleagues in all innocence and without any malice, inadvertently failing to put down where they've been a potential sleeping partner in an organisation, or had a shareholding or an interest, or a close loved one has. My counsel to all directors is just put everything down there, and then there is can be no accusation. Just a simple example, I put down that my son works for our auditor, even though he's not an auditor. So I think just total transparency is what I would counsel. So if you're not happy to approve those registers, please raise a digital hand. Duly approved, thank you. Then the fit and proper persons annual declaration. Again, Sarah, you've been examining our souls on this one.
Thank you. So all voting and non-voting board members have recently completed their fit and proper person declarations, and to confirm that they are all fit and proper person and good characters. So this is just to be formally received and noted, please.
I'd like to show that to my fourth year teacher when I was at Free School, who did question aspects of my character and hard work. Any questions on the fit and proper persons register? If you're not happy to approve, please raise a digital hand. Duly approved, thank you. Then we'll move on to the annual review of KPIs, including the quality indicators. So we can give you a rest. Harkema, over to you.
This report simply just sets out key performance indicators moving forward. It's all in line with the operating guidance that's released in December, and has already been incorporated into all of our scorecards and dashboards, so it can be part of operational management moving forward. So it's just looking for approval for those.
Thank you, Harkema. Any questions, colleagues, on these on the KPIs? Again, it is for approval, so please raise a digital hand if you're not happy to approve. Duly approved. Sarah, you only had a couple of moments off. So the G6 license condition, annual board self-certification, back with you.
Thank you. So this report and the next report are both for the board to consider and self-certify against each of the statements. Since submitting the reports, the new provider licence has been published with effect from the 1st of April. The board's self-certification requirements for this report and the next one have been removed from the final modified licence. The self-certifications do keep the board's focus on compliance and governance processes. However, the decision to remove the reporting requirements has been made to streamline the requirements and reduce burden. It's recognised that there's a range of other reporting mechanisms that would continue with that, such as the annual report, the annual governance statement, and through the CQC well-led reviews. However, Glenn, Russell and I are going to meet to talk about the board's future reporting requirements on these two elements, because we feel that perhaps we should still be reporting this through the board, or at least the audit committee. So happy to take any questions and propose that these be considered and self-certified. Thank you.
Thank you very much, Sarah. Colleagues, you've all had the time to have a look at the G6 licence. Any questions on this and the corporate governance statement? If you're not happy to approve the G6 licence, please raise a digital hand. Duly approved, thank you. And then if you're not happy to approve the corporate governance statement and other declarations, please raise a digital hand. Duly approved, thank you. Thank you for all your hard work, Sarah, on each of those elements. So we then get into the meat of today's meeting, which is the performance review and assurance statements. And we start off with Glenn's Chief Executive report. And just before Glenn gets going, Glenn, I would just like to celebrate the fact that, again, you've been identified as one of the top 10 chief executives in the country. We're very fortunate to have you, and thank you for your hard work and leadership. But over to you. How are you seeing things?
Thank you, Chairman. I feel like I ought to declare that my third year school report was a bit ropey in places as well, but we won't go there now. So I'm going to just give you a bit of an overview of some of the things that are going on in the NHS at the moment. I mean, one thing we're really delighted to be taking part in is the Integration Frontrunner programme. So a very small number of systems chosen for that, and Becky Hale and Jenny Bannon have been leading the work on that, and you can see a a comprehensive update in my report about some of the things that are going on there. And we're very much poised now to start to put in place this new model of delivery, which we're convinced will demonstrate that by investing in these pathways, we can reduce the inappropriate activity within the acute setting, but also save the whole system money. And that's why this is a really important national programme, because the learning from what we're doing in Warwickshire will then be rolled out across the NHS. Then I report on the National Staff Survey. It is in detail later on in the agenda, but I couldn't let my report pass without congratulating the leadership team and everyone in the organisation for creating the kind of organisation that it is, and to see us up there on that list of the top 5 organisations in the NHS in terms of would you recommend it as a place to work, I think is a really great result, particularly when you look at the other trusts that are there. That said, within the survey, there are always lots of opportunities for improvement. We had a look at those this morning, and we also looked through some of the individual comments that staff members made in the survey, and those identify some areas where we can further strengthen, further improve, and we'll be on to those over the course of the year. I then report on the last round of junior doctor strikes, and as I sit here today, I'm more worried about the next round. Everyone managed this situation incredibly well. Harkamel and team particularly for the way that they coordinated the arrangements to ensure that we saw the absolute minimum disruption to our services and to patients. And we had a very low level of cancellation. But particularly to our consultants, our other senior clinicians who filled in some of those gaps. And we refer to junior doctors as if they are not very senior, but there's some very senior doctors amongst our junior doctors, and they're very core for the delivery of the services that we have on a daily basis. So when we go into the 11th to the 15th of April with this further, more comprehensive strike, which follows immediately after the Easter bank holiday, it's with some trepidation that we put those plans in place again. This is also a period where there'll be potentially more annual leave amongst our consultant workforce, and potentially, the goodwill could well suffer the more that these kind of incidents go on. So, as I say in my report, it needs a remedy, and I look to national colleagues and union leaders to try and get to that place. There's then some update from the ICB. There's update from the system review meeting, and probably gives me the opportunity to steal Adam's thunder and confirm that we delivered on the 78-week promise. Elsewhere in the system, that wasn't so. So as an entire integrated care system, we did not deliver the 78-week target. So that was a point of some discussion during that review meeting. Pleased to report that our colleagues in George Eliot did, and even in Wye Valley actually, where they had a real challenge, they ended the year with just a tiny number, 78 weeks. So well done to the entire group on that. I shared with the chairman actually earlier today that the latest report, which shows the amount of elective activity that each acute provider in the Midlands was doing over the last week, and in the top 4 positions there are the 3 trusts of the group. Northampton got in there in the middle of us as well, so well done to them also. But it's really good to see that focus on, I suppose there's some of that links back to the strike acts, and that focus on making sure that we deliver the activity and we don't cancel patients and we keep the show on the road. I refer to the NHSE headcount reduction. I won't read all of that out, but there is an opportunity for us to bring some of those skills into our organisation as we move forward in the lead provider role, which I will touch on a little bit later on. And then the only other thing I wanted to pull out was well done to Sophie and team for securing £8.1 million worth of capital for decarbonisation of the site, which is a really great opportunity for us to deliver on our big move of leading the NHS on carbon reduction. Happy to take any questions.
No, thanks, Glenn. And just a big call out on the more from our great teams, the Warwickshire Paediatric Palliative Care team, which you refer to in your report. And I'd particularly like a call out related to that to Bessie Scrivens and the great work she does on our maternity bereavement services. Big call out to them. Thank you. Questions or perspectives to Glenn? Okay, so Glenn, you obviously indicated the junior doctors was, the junior doctors strike was a concern. How disruptive do you think it will be? And there's no real sign at the moment, just to see whether you can agree with me. There doesn't appear to be any real movement at the moment on either side, which is very worrying for our elective recovery. What would your perspectives be?
Yeah, it's disruptive on a number of fronts. I suppose, firstly, I would refer to the individual patients that we may have to cancel during that period for any kind of planned activities. We'll obviously ensure that urgent care is safe and maternity services are safe and critical care and all of those essential emergency services run. But in order to do that, we may have to move some staff to those areas and cancel some elective work. We'll keep that to the absolute minimum. We'll try and maintain cancer services and urgent emergency surgery. But it's a period where some things will have to give. I suppose the other thing for me, though, the disruption to the organisation, to Harkamel and team, managing those several days and leading up to those several days takes away some of our capacity to be doing some more strategic things, to be getting the plans together to deliver on the financial recovery plan that Kim's just gone through. So, that can't be understated either. So I suppose we'll get through this. But the sooner we're back to focusing enough of our time on strategic things, the better.
Thank you, Glenn. Sue, William, Tracy.
Yes, thanks, Chair. Glenn, you mentioned lead provider, and I think you said you'd come back to it. I read that there's a delay in some responsibilities moving from ICBs to trusts, and I wondered, was this unexpected? And what does it mean that SWFT needs to pay attention to this year to ensure that we carry on in that direction?
Good question. Yeah, when I said I'd come back to it, I was going to come back to it later, actually, when I look at the review of the objectives for the year, because it's the only objective actually that we've red rated, that we didn't make the progress that we wanted to. Now, some of this is wrapped up in the changes that have been put in place through integrated care systems and potentially a degree of nervousness around doing different things with that new legislation that we're trying to work through with our ICS colleagues. We have a way through it, and we looked at that earlier on in the year, and we put ourselves forward as a group to be a provider collaborative innovator. And through that programme, which is only just commencing, we will get national support to help with some of the regional and local concerns to demonstrate how quickly we can move and flex the rules to put those arrangements in place. I'm very clear that it's the right model for us, and indeed it's what our entire strategy is based on. But I'm also clear that we haven't got all the skills to do that. So, part of Becky's role being shared with the local authority was to bring some more commissioning skills into the organisation. And there's some great people in the in the ICS from the CCG historically that can help us with some of that other commissioning. So I think we've now got a vehicle to get there. I suppose we're always keen to get on and do things quickly in this organisation, and that's hopefully we can up the pace on that this year.
Thanks, Glenn. Always good to watch those Freudian slips. Any other questions, Glenn? Okay, so Adam, welcome.
Thank you.
Performance report. What would you care to pull out?
Thanks. I will pull out the headlines from each category. So in terms of the Chief Nursing Officer's report, positive news regarding the reduction in falls, patient safety and grade 2 pressure ulcers. All of those have reduced, and we've also got an improved picture around nursing staffing. Slightly more on the negative, we have breached the target for C. diff and E. coli infections. Now, we had quite a detailed discussion in the board workshop about this morning, and I think we understand the picture there a bit better. We also completed RCAs into each of those breaches, but work there continues and will be a focus for the next year. In terms of operational performance, we saw during the period of this report an increase in our ED performance, recovering from the low in December. And I think this demonstrates the team's improved ability to cover from some of the really difficult days that we've seen over the winter. And that has continued to improve. We're on track, I think, for a good day today, and certainly over the last few weeks, we've seen improvements in performance there continuing. Bed occupancy remains really high at 100%, and has been challenging, I think, in terms of hospital flow. We have, as Ben stole my thunder, I'll steal Harkamel's. We made good progress on our 78-week target during the month of the report, but we have met the target at the end of the year, and I think that is a reflection of the hard work that Harkamel and her teams have put in to that for our patients. So really good news. We've also seen a drop in diagnostic waiting times. Just under 90% are now waiting less than 6 weeks, even with a historic high there on the waiting list. So again, I think that shows the hard work our operational teams are putting in. Cancer performance, however, remains a challenge, and I think one of our most significant concerns, and that has really been compounded by the significant increase in referrals we've seen. I know Harkamel will cover that in more detail as part of her report. In terms of the Chief People Officer's report, some good progress with times to hire, which continue to reduce. And some really good work going on in the team to increase our talent pool, recognising our need to fill substantive roles and particularly focused on the areas where we need to fill those roles. Finally, in terms of finance, the month was challenging and we had an increased run rate. I think we already referenced, we had originally planned a £3 million surplus for that year, and that was based on assumptions around NHSE funding for our community diagnostic centres and integrated care board funding to reimburse 12 beds that have been in use at Ceru in Leamington. We were notified that we wouldn't receive funding for either of those areas during the period, so as a result, will not meet and did not meet our planned service, but we remain on track and will meet a break-even position. We've already discussed the impacts of the strikes as well that Kim's team are mitigating. So those are the headlines I was going to cover, but there will be more detail in the individual reports.
Super, thank you, Adam. Very clear summary, and best wishes from all of the board in the new role. Any questions to Adam, or should we dive into the detail? Okay, so we'll start off then with quality and safety, and Charles and Sarah. Just before you get going, delighted to see Fiona Burton on the call in the background, so to speak. Fiona, we're really pleased to have you back, and I know we all owe a great debt of gratitude to Sarah for the phenomenal work she's been doing, and April is a handover month. So Sarah and Charles, what would you care to put out?
Thanks, Russell. I'll start if I may. So as Adam's just highlighted, February remains an exceptionally busy month operationally, and so I think it's a real tribute to our teams that the quality metrics remained incredibly stable and continue to benchmark very well nationally. I'm pleased to report that in response to actions we've taken in response to the VTE risk assessment dips, we've seen an improvement in February, and actually we've seen a further improvement in March. With regard to IPC, we heard at the board workshop this morning that we'll finish this year actually reporting slightly less Clostridium difficile and E. coli than we did last year. So whilst we have breached the target that we were set by NHSI, which is disappointing, that is in the context of that is that nationally and regionally there has been an increase in both C. diff and E. coli. So more work to do, but I think it is good news that we have seen a slight reduction in both of those infections this year. I think, as we were reminded this morning, that IPC will remain a really hot topic and key focus actually for all acute organisations, including ours, during the next year. In terms of patient experience, I'm very pleased to advise the board that our patient experience data also remains very good overall. This month we've included some narrative on the way we've been investigating and learning incidents, just to offer the board some assurance around the way we closely monitor our response and learning when something does go wrong. I'm pleased to say that we remain a high reporting organisation, which is one of the indicators of a patient safety culture, which is good. Lastly, I'd just like to highlight that we've included a staffing triangulation report for our acute inpatient wards in this month's report. It's good to see that there are no wards across any of our acute areas where the triangulated data is causing significant concerns, and there are no red metrics where there is not a plan or an explanation. So just to give a couple of examples, in maternity, you'll see there's quite a few staffing incidents, and our colleagues in maternity, both on the midwifery and the obstetrics side, are very mindful of the national requirements to report when anything isn't exactly as it needs to be. So, for example, if we have to make some staffing changes across our maternity teams to protect one-to-one care in labour at all times, they're very good at reporting that as an incident. So it's actually good that we see lots of Datex reports around staffing in maternity. In terms of pressure ulcers, the data includes ulcers which are inherited, as well as those that are required while patients are in our care. So on an intensive care unit where they're caring for our sickest patients, we would expect them to both inherit patients that have already established ulcers, and also the patient group that they're looking after are the most likely to develop pressure damage. And just by way of closing, just to say that our teams are working on developing that dashboard so that you see the same triangulation for our community teams, where we can look at their quality metrics and their staffing on one dashboard. So I'm very happy to take any questions.
Okay, just before we get to that, so Charles, anything you'd like to add on quality and safety?
Well, I think that the mortality is really the issue that's worthy of discussion. You will see in the mortality report that our shimmy is on the rise. Now, the overall figure is within control limits, so it's not statistically significantly different from England, but we are seeing a rise in shimmy, and we've done a lot of deep dive work into this. I think the first thing to say about it is that this is not a benchmarking indicator. It's an indicator to try and point to changes that then need investigation. And the increase in risk-adjusted deaths are largely in patients with pneumonia. And when you drill further into this, despite the fact that it looks as though the sort of dependency and severity of the illness of patients coming into the hospital have increased, the actual depth of coding and the amount of comorbidities has decreased, which means that the model is tending to show that patients were less likely to die when they may be more likely to die. The other reassurance we have is that every case is looked at by the medical examiners for death, and they obviously to take into account any concerns anybody's brought up. So the likely cause of this is related to the way things are clinically recorded and then coded, and there's a series of actions to address this and to look at it further, and also some audit of cases. And I'd be very happy to do a presentation in board workshop about these mortality indicators, because it's a complicated matter.
Thank you. If we can make sure we do that, Charles, that would be good. So I know we're going to talk about cancer services and issues around that under Harkamel's report. So I'll be asking Charles for your perspective on that at that point. But any questions to Sarah or Charles on the areas that they covered? I have to say, I've been spending quite a lot of time visiting different wards recently, and I have had uniform feedback from patients about the care and kindness of our nurses and frontline teams. So I think members of the public can be assured that we do have, as indicated in our staff survey, which we'll come to later, some very special people who work for us. So well done, Sarah, Charles, Harkamel, Fiona, everyone involved in nurturing that sort of environment for our staff to be able to deliver that sort of kind, caring attention. Shall we move on then to the, if you like, operational performance? Over to you, Harkamel.
Thank you. So I start my report off by highlighting our 4-hour performance, and I am really proud that we managed to hit 67.5%. It isn't anywhere near where we want it to be and where we want to be, but it is our highest performance since March, and against a really challenging winter and a really, really busy month. I think that is really impressive. In terms of some of the things that help us with that, same-day emergency care really has to be our focus, and certainly we can see that when we have good flow through our SDEC areas, that's when our performance is better. We are challenged with our bed occupancy, so the planning guidance talks about getting us to 92%. We are always at around between 96 on a good day to 100%. So today we're having a good day and we're on 96%. But it's just a highlight to everyone just how tight the capacity is and how you know, in the absolute detail of every single patient, and we need to be to manage every single patient through and maximise our opportunity. But we did move from 27th position nationally to 21st, which I think is brilliant. The aim for next year is to hit 76% by the end of March next year, but internally we have agreed that we want to be hitting that from April at the you know, as our bare minimum. So that's what I'll be managing us against. In terms of outpatient, in terms of elective activity, we continue to perform well. We had a very busy month in the hospital. We did 100% of our admitted and our outpatient activity when compared to 2019-20, and our outpatient first appointments remain well above target. Our waiting list from a routine perspective continues to grow, although the rate at which it is growing is slowing down slightly, which is relieving, I think, for all of us. And although it's been said twice before, I'm very proud of the elective division for achieving no 78-week waits. I can't quite impress how stressful it was to meet that that challenge that we've sort of set ourselves. And I would like to extend a special thanks to Sarah Lee, because it is, you know, in no small part due to her determination. Adam did mention briefly around our cancer performance, and I'm really sad to say that our cancer performance is not improving. In January we saw 46.4% against the 62-day standard and 58.5% against the 28-day faster diagnosis standard. Our demand through the 2-week wait referral process continues to be record numbers, even in the first 2 months of this year. And I know I said that every single month last year as well, but that pattern certainly continues. The conversion rate is sort of back to where it was, but with the overall denominator being bigger, the demand on cancer services and that whole pathway clearly is challenged. And I'll finish my my summary and then come back to oncology, if that's okay. The last thing just about the ops update I wanted to say was around the 2-hour The urgent community response performance is extremely high, and I just wanted to say a happy first anniversary to that team, and a big thank you to them for everything that they do. Glenn's briefly touched on it, so I won't go into it too much, but I have included a detailed narrative of how we approached the strike that we went through on the 13th to the 15th of March. There was a lot of planning that went through that, and we essentially adopted our winter planning approach and utilised our silver framework, which I think worked really well. I think the organisation is now in a really strong rhythm of understanding the ask, and certainly we're applying that methodology moving forward. I am really sad to say that we cancelled some patients. We cancelled a smaller proportion compared to other trusts, but any cancellation, in my opinion, is one too many. Learning from this time, last time we tried to hold our nerve for as long as we could, and cancelled quite close to the day or on the day, because if there was any chance that we might have DUPs coming in that we didn't accept to strike, I would rather that than cancel people. That did mean that a lot of people had found out on the day, which I can appreciate is really stressful and can be distressing for patients. So we learned from last time we had around 80% of our junior doctors on strike, and we've proactively looked at if we know that there's absolutely no chance, given that we've got a significant cohort on leave as well. We are going through and cancelling those patients now. The numbers will actually be the same because we had already taken some activity in line with the Easter holiday. The other group I just wanted to say a big thank you to are the bookers. The bookers had a phenomenal piece of work to do in terms of bringing all of those patients and assuring them that we're booking them in. So a very big thank you to them. So if we can just come on to oncology then. Oncology has been a pressurised service for a number of months and potentially years at SWFT. And it is in line with what I've just said around the demand through the 2-week wait pathway is always historic. So with a slightly higher conversion rate month on month, even though it is levelling off, the denominator is bigger, so the demand on oncology, surgical and then oncology services is bigger. Currently, we have our oncology cover provided through an SLA with UHCW, and we have recognised that this needs refreshing for a number of months, for a number of years. Probably most of them in closest history, the last time we looked at it was around when we went live with Stratford, and that's when we put a locum in place to try and cover off some of that demand, knowing that we wanted to provide oncology services over at Stratford. And at that time, UHCW were unable to provide us with any more consultant capacity. As I've said, we have got increasing demand. When you then tie that in with a retirement of a consultant at UHCW, that does leave us with a gap. So in terms of where we are now, we are working with our system partners to try and look at how we might even out the waiting list, or have a shared view of what our waiting lists are, so that we can hopefully move about or consider where that capacity is provided. And as I say, our system colleagues are supporting us on that. Moving forward, though, we do need an SLA that meets the growing demand of this. We know that our services are under pressure, and it's really important that we maintain care close to home. So we're really keen to look at the service provision that we've got now and make sure that that's fit for purpose. And not just in terms of clinic provision, but also in terms of clinical leadership. What does our acute oncology provision look like? Is there space for more middle grades, and how do our nursing colleagues work across the patch? So we started to put together a version of what an SLA could look like moving forward. We do have, and I'm just conscious that this might come up as a question, so I'll head this off now. We have had challenges around our aseptic unit, but that is a small, almost acute problem that we're facing here. The issues that we're facing in oncology are actually the delay to the first oncology outpatient appointment. It's then after that when a patient might need chemotherapy and we need our aseptic unit to make the drugs, that we have a small delay. That said, I really would like to thank the aseptic team and the pharmacy team at UHCW, who've really helped work with us to improve capacity within the department. And from April, I think next week, we'll have an additional 70 hours of pharmacy capacity within that team. And from August, we'll be back where we were. So that's where we are from an oncology perspective.
Okay, thank you, Harper. Can I just go back and just make sure that things are clear in my own mind? and maybe members of the public. So an SLA is a service level agreement, and oncologist consultants are provided by UHCW. They work in Stratford and other places as part of that SLA, and we pay for their hours through a service level agreement. I'd just like to put on record my thanks to Dr. Clive Irwin, who's recently retired. Clive Irwin has worked with us for UHCW, but as part of that SLA for a number of years. He is a quite extraordinary oncologist, has served a number of our citizens and patients extremely well. And Clive, thank you very much on behalf of everyone at SWFT and in South Warwickshire for the years of service you provided. Because of his exceptional nature, as I understand it, he's very difficult to replace. And that's where the challenge has been, as I understand it, correct me if I'm wrong, Harkamel, is replacing the hours and productivity of Clive Irwin has proved very difficult for UHCW to provide. Is that correct, Charles? I just want to make sure we're understanding the problem.
I think there's a little bit more to it than that. You know, if you look at cancer and the aging population demographics, you know, we have a picture of increasing demand and restricted supply, in that you know, the West Midlands in general is not blessed with large oncology numbers, and UHCW have had difficulty recruiting, which goes back to when we opened the Rigby unit in Stratford, and had to get a locum. So we've been constrained for a long time, and then on top of that you have increasing demand, and then Clive's departure, as you say, he was able to treat patients with multiple different cancer sites, and the neuro-oncologist can only do one. You know, it gives us a particularly acute problem on top of all of that.
Super, thank you, Charles, for that clarification. So we've got an issue of demand increasing a lot, our supply of oncologists being reduced, but our supply of oncologists is from UHCW. Glenn, I know you've been doing quite a lot behind the scenes to sort of address this at a system issue, because it is a real issue for our patients and their families, and in particular the need to keep things local at place, because if you're diagnosed with cancer, you want to keep things local. Glenn.
Yeah, so I echo your comments about Dr. Irwin. He was a great consultant who served South Warwickshire and Coventry and Warwickshire really well for a number of years. So he'll be missed whatever we do next. However, just trying to get assurance that we are trying to replace him, and we are looking at the increased demand pattern, because as Harkamel's already said, our increase in demand appears to be the greatest in the entire region. So it's a 30% increase in 2-week wait referrals. So as well as coping with the demands that we already have, which were high, it grows, and it will keep growing. Hopefully not at such a high rate, but it will keep growing. So the conversations around the service level agreement are going on for too long for me, and notwithstanding those, there's obviously an increasing demand that we need to have a workforce plan to respond to, and Dr. Irwin signalled his retirement plans some time ago. So I've written to the Chief Executive of UHCW seeking assurance around the plans to replace him, but then also to meet the growing needs that we have. I've had some responses back so far, but still not had clarity on why we've got ourselves in the position we're in. But those conversations will continue, and we've certainly confirmed that we would like UHCW to be our tertiary partner and to provide those services on an ongoing basis. But obviously the needs of patients come first, so we'll continue to reflect on that depending on the response that we get. In addition to that, though, as Harkamel said, we've got our own issues as well that we need to tackle. So the aseptic capacity, it's a really interesting one, actually. And I met with our chief pharmacist earlier on in the week, and I'm pleased to see that we've made some inroads into that. Our aseptic service is the only service in the entire Coventry and Warwickshire system that is able to do work on behalf of other trusts, because we hold the MRHA license to do so. UHCW don't hold that, George Eliot don't hold that. So it's actually in the system's interest for our unit to be able to respond to that demand. And there has been really good support from the pharmacy team at UHCW. And so I'm satisfied that kind of latest issue will be managed, and we'll obviously also need to continue to grow our specialist nurse workforce, etc. But we do need to resolve this consultant input issue as a matter of some urgency. So I'll report back to the board when we meet next on where that has progressed to. I also appreciate the help that we've had from ICS colleagues on bringing this to a head also.
Thanks, Glenn. Please do keep us briefed. Any other questions or perspectives on what we've heard from Harkamel and then Charles? David Spaggart?
Right. Yeah. I mean, I'm interested in the high incidence of 2-week wait referrals. Presumably they're all from GPs, I presume. But you say the conversion rate is similar to what we were experiencing before. So presumably these aren't inappropriate referrals, they are simply more referrals. And have we got any idea why South Warwickshire appears to have more people presenting than the rest of the West Midlands for this? I mean, is there something we're doing right, or is it something we're doing wrong? It would be the two questions I'd ask.
Charles?
Well, I can commit just to clarify about the conversion rate. Throughout last year, we did see an increase in some tumour sites with the conversion rate. So I think I've said before, across some tumour sites, breast, we had, for example, we had an increase of like 1%, which is not statistically insignificant, but we have now levelled back up to what the averages were pre-COVID. So yeah, to your point, it does suggest that these most of these referrals are appropriate, and we have been doing audits to see if there are any practices who are out, referring outside that guidance. And so far, we haven't managed to find anything. It's just, it is a volume thing, and we've asked the system for support in terms of trying to help us manage some of that and signpost elsewhere. And if there's, if there is something underlying that we can't perhaps support in terms of trends as a provider. But I don't know if Charles has got any other insight on.
I mean, so my concern is that in the early days of COVID, we always talked about we naively called it the fourth wave, thinking it was the non-COVID effect of delayed diagnoses. We now know that fourth, it was fifth or sixth. I've lost count now. But is it, because clearly that should be universal across the country. So I just worry, are we finding it earlier than some other areas, or other, I'm intrigued to know why, because there can't be anything different in the South Warwickshire area to the rest of the West Midlands. Well, maybe there are some differences.
I can speculate, David. I mean, first of all, we do have an older population than most, and cancer prevalence is very much related to age. Secondly, you could speculate that the quality of our primary care is picking up on the COVID backlog quicker than others, but that's speculation. The other thing I was going to say that the ICS is planning to review oncology as a whole, and that's a good question to ask them. They're going to have some independent input into that. I certainly want to get us well prepared to contribute to that review, and also encourage some patient involvement, because as a cancer patient myself, I would echo the chairman's point that the last thing you want to do if you're not feeling well is travel to a strange unit and negotiate with car parking and everything else like that. So I think patient involvement is very important.
Well said, Charles. Okay, we're going to stay close to this team over coming months, but Glenn, your focus at senior colleague level is obviously disproportionately important, and we need to ensure whatever the answer is, it delivers one of two things: either improved patient outcomes or lower cost of delivery. If either of those can't be shown to be improving, then we need just the oncologists we pay for through the SLAs. I'll leave it with you, and we'll keep briefed. Colleagues, happy to move on to Gertie? Need to pick up the pace a little bit. Gertie, over to you.
Thank you, Chair. And mindful of time, I'll take the report as read. There's only a couple of items I want to take out. Adam has mentioned it already, but I will pull out the significant improvements in recruitment and time to hire. It's really positive to see our nursing time to hire was reduced from last July at 20 days to just over 8 days in February. Equally, our clinical support workers have gone from 33 days to about 10 days. Still lots of opportunity for us to improve, and the team are working on reducing that further. So that's really positive. The sickness is also reducing. We are still above our target, but we do monitor this robustly through the finance and performance meetings on a monthly basis, and I am sure that there are plans in place in each of the divisions to continue to support staff back to work. Appraisals also are slightly below, but we continue to work with the divisions. Appraisal is very important. Glenn's already mentioned the staff survey, and I will come to it again later. Appraisals is a really key part of how our staff are supported and feel valued, so we do continue to work on that. I'll take the rest of the report as read, Chair, conscious of time, but happy to take any questions.
Thank you, Gertie. Any questions or perspectives to Gertie? We did talk for members of the public's information about if you like, a rallying call to members of the public and to our own staff around two key phrases: be kind, be polite. The staff survey showed that a third of our staff have experienced abuse from members of the public. There is never an excuse for members of the public to abuse or be impolite to any of my staff. So, and we will react accordingly to that. Citizens should be grateful for the care and attention they get from our frontline team. So be kind, be polite, I think is a good sort of mantra for us to focus on. Gertie, well done, particularly on that reduction in time to recruit. I think that reduction from over 20 days to 8 days is great. Okay, well, we've talked about the numbers a bit. Kim, anything else you wanted to pull out in terms of numbers?
Just to Adam's already picked up the fact that we're delivering a break-even position for the month 11 report. We're just finished, obviously, the financial year, and we're finalising the outturn numbers as we speak. But I wanted to bring to the board's attention that we are on track to deliver on the right side of a break-even plan. It was disappointing that we didn't deliver the surplus plan as we had originally planned, but they were for reasons that were outside of our control. In terms of agency, although agency spend remains high, it was positive to note that as a percentage of our pay, we did see a reduction in February, which is a positive indication. So look forward to see what that looks like in March. We did incur some additional costs on the back of the junior doctor strike from March, but we have been able to mitigate some of that and most of that. So in order to ensure that we do deliver the outturn position that we had forecast. I think where we are now is about looking forward into next year, and we've touched on that when I discussed the plan for next year, and that's the focus really that we're working on now.
Okay, thank you, Kim. Any questions or perspectives to Kim? Okay, so all of the focus now. It's now the 5th of April, 5 days in. Another 360 to go to deliver that break-even plan. Okay, so we'll move on then to the learning from deaths, which we've covered off. Thank you, Charles. So we'll move on then to the apologies. The patient experience quarterly report. Sarah, back with you.
Thank you, Chairman. So I'm just going to highlight a few key points, if I may. So as I've already said, our overall data confirms that the majority of patients report a good patient experience. In February, we saw the lowest month this year for PALS contacts. And I think that reflects some really good work that's been done across particularly surgical specialties, which has reduced PALS inquiries, particularly about forthcoming appointments. So just wanted to offer my thanks to colleagues that have been involved in that piece of work. So it's made a real difference to our patients. We've continued to see low numbers of formal complaints. And our analysis shows that there's no one clinical area which is standing out. Again, I think that's good news for the organisation. But of course, complaints, it's all about our relentless focus on learning. And so just to highlight that we have made improved communication from first contact to discharge a quality priority for this next year. It's actually really good to see that focus has already led to a reduction in the proportion of complaints where communication was a key theme. So I'm really pleased to see that. Glenn's already mentioned our volunteers, but I just wanted to close by thanking our volunteers. The report details how we now have volunteers. We've increased our volunteers so that they're really able to support the organisation in times of pressure. So, for example, they now cover A&E 7 days a week. And we're also working with Macmillan Services to train volunteers to support some of our patients that we care for that suffer with dementia, which is really great to see. And the support of volunteers really does help us enhance patient experience. So we're very grateful for all that they do. So I'm very happy to take any questions on any more detail.
Thank you, Sarah, and thank you for your hard work. Any questions or perspectives to Sarah? Okay, so we'll move on then to the annual report of signing and sealings. Sarah, come in.
Thank you, Russell. This report's just for noting the information. It outlines all of the documents and contracts that have been signed and where appropriate sealed throughout the year. As you can see, we've been rather busy this year. Thank you.
Thank you, Sarah. Any questions or perspectives to Sarah on the annual review of signings and sealings? Okay, so the Audit Committee report for the 8th of February. In Richard's absence, I'll take as read. Are there any questions to colleagues on the from colleagues on the Audit Committee report to the 8th of February? Okay, so we'll move on then to the Foundation Group Strategy Subcommittee report for the 28th of Feb 2023. Simon, is there anything you'd like to pull out of this?
Thank you, Chair. No, I'll take the report as read, and I think my only observation would be is I think the committee has become quite a mature organisation and reflects the three parts of the organisation working together very closely in harmony, I think in much greater harmony, which I think is excellent.
Thank you, Simon. And we do have our 3 board meeting next month in May for members of the public to come and join us and see those 3 boards working together in that forum. Any questions to Simon on the subcommittee report from the Foundation Group? We'll move on then to clinical governance. David, what would you like to pull out of this?
Well, I have to say the things that I was going to pull out have already been addressed earlier on in the meeting. You know, the mortality indicators, the aseptic service, and indeed some of the oncology issues that have been raised. So I've got nothing else to add, really. Good.
Pleasing to see the board doing its job in advance of the Clinical Governance Committee. Or in
I make an assumption that they've read it first and then they've acted accordingly. I shall take it that way round.
How many questions to David on the Clinical Governance Committee from March? Okay, thank you. And thank you for joining us today, David. I know you're just back from a long holiday drive yesterday, so we appreciate you joining us. We'll move on then to issues of strategy. The first is the year-end report on annual trust and foundation group objectives. Glenn?
Thank you, Chairman. So the dust hasn't quite settled on the year just ended because there's obviously a few bits and pieces and numbers to add up, but we're sufficiently clear of last year for us to report back on progress against the objectives that we agreed for the year. And these periodically have been reviewed by Council of Governors as we've progressed during the year. They'll also, once signed off by the board, feature as part of our annual report, and I'll obviously refer to them also in our annual governance statement. We don't set ourselves easy objectives as an organisation, and the ones that we looked at last month, actually for the year that we're now in, reflect that also. So what I always expect to see when we get to the end of the year is some green and some amber and some red, and we've probably got it in the right proportions from what I can see on this one. Quite a lot of green, despite the challenges of the year that we've just been through. There's some really good strategic progress in a number of areas. There's a number of areas that I've rated amber that still need a bit more work, and the one area that I referred to earlier that didn't make the progress that we wanted it to in terms of some of those place-based leadership roles. Doesn't mean there hasn't been progress, because there has, and indeed the framework through which we take that forward in the Provider Collaborative Innovators programme will help us to accelerate it, as I reported earlier. So I'm happy to take any questions on those, but also to just add my appreciation to the execs who, so if there's any questions on any of these detailed areas, you can see which exec I'll be pointing to. So it's a well done to all of them for the progress they've made over the last year.
Well said, Glenn. Thank you, and well done to you for your overall leadership during the last 12 months. Any questions or perspectives to Glenn on the annual trust and foundation group objectives? Looking forward to 23-24 being a breakthrough year in terms of lead provider status and the integration frontrunner work, so lots of excitement to come there. The board assurance framework and the risk quarterly report for Q4. Adam, what would you get to pull out here?
A few points. So there are new risks on the BAF relating actually to the conversation we've just had around lead provider. So that's 9B and 9C. And again, that reflects the discussion we've had around the risks there. The report confirms our risk appetite for objectives in the strategy for next year, and that's based on the board workshop session we had last month to discuss those. I think important to note that Risk Management Board met a few weeks ago on the 13th of March and reviewed the significant divisional risks, and the register is included with the papers. I think the final point that's worth just dwelling on for a moment is the paragraph in the report around Entonox exposure. So board colleagues will be aware this was raised as a national issue earlier this year in February, where levels of Entonox in particularly in delivery suites, but in other areas of hospitals where Entonox are used, was noted to be a concern. Responding to that national concern, we have used a independent company to do a survey in our delivery suites, and I'm pleased to report that that survey, which was performed over 24 hours, didn't highlight anybody being exposed at all close to the limit for Entonox exposure. I think it's important to note, though, that survey was only conducted over a limited period and only in maternity. Further NHSE guidance has now been released, and we are responding to the action plan associated to that, and it's likely we will put in place more routine reporting and surveys as part of that, and that will be reported to Health and Safety Committee in due course.
Thank you, Adam. Any questions to Adam on the BAF and risk quarterly report? Sorry to do this to you, Adam. Just two from me. The one is, I'm not sure the profile of the junior doctors' strike is quite as high on the risk register as I'd like it to be. I don't think this is going to go away in the short term. So can we find a way of making it a higher profile issue? Because I do think it's going to be one of the big issues for Harcomel to be able to juggle. The The second is on 1831. Correct me if I'm wrong, Sarah. I think TNB signed off. This is the issue of midwives used for scrub recovery post-operative issues. I think the TNB has signed off a significant investment in new resource into the midwifery team to cover off that risk to the order of £400,000 or £500,000. Am I correct in that? So
you go for it. Yes, that's right. Russell, I'm really delighted to say that management board have approved a business case which will give us 24/7 trained theatre practitioners in scrub in maternity theatres.
okay, and I think it's the first time we've ever been able to have that level of assurance, isn't it, Sarah?
And that's right. And actually we have taken action in the meantime. So we are using agency staff to enhance the number of theatre practitioners we've got providing that service at the moment. So just to make sure that we're maintaining a safe service.
Super, thank you. Really good decision, I think, from TNB there. I know it doesn't come to board because of the sign-off limit, but I think that for our citizens and the growing families we've got in all of this house building that's going on around Warwick, Leamington and Stratford can be very assuring for young families. We'll move on then to the items for noting. And the first is the summary of ratified policies. Adam?
Yes, there are 2 ratified policies, 1 minor amendment, 1 new policy, but I will take them as read.
Any questions on the ratified policies? They're duly noted, thank you. And then we had a big session this morning on the NHS staff survey results from 2022. Gertie, what would you care to pull out?
Yeah, I'll be brief, Russell, but so we've mentioned it a number of times, and Glenn has covered. This is one of our most important indicators, particularly gives us a good reflection of our staff experience and culture. Really pleased to see that once again SWFT has maintained good performance and is above average or close to the best across all the 7 people promises and the 2 additional areas of staff engagement and motivation and morale. Really positive to see that SWFT was noted in the top 5 in the country for people recommending the organisation as a place to work. Really fantastic. Lots of areas of good practice, lots that we can be proud of and can share across the organisation. Unsurprisingly, there is a decrease in satisfaction with pay, and we have to bear in mind that the staff survey was completed in October to December last year when quite a number of our trade unions were balloting for action. That's a national issue, not one that we in SWFT control. There's also some decrease in terms of satisfaction with flexibility, and the public will be aware that one of our signature big moves this coming year is in being a very flexible employer, and we will continue to move on that. We've seen an improvement and reduction in staff feeling discriminated against, and again a reflection of the work we've done collectively as a board over the last 12 to 18 months in really promoting this area. And each division has set its own priority areas, and we can see them in the report. As I've said, we have got great experience and great improvements in the organisation, but not everybody always has that experience, and there is a great opportunity for us to share our good learning and improve everybody's experience. So the real focus and set out at the end of the report is on the what next and what are we doing, and the plans to keep working and developing our culture of kindness and politeness, as you've noted, Chair. 3 priority areas for us really is being a very flexible employer, engaging with staff to understand what they want and what would support them and improve their experience, and embedding our values to ensure that we have kindness and politeness on an everyday basis. I'll leave it at that, but happy to take any comments or questions.
Thank you very much, Gertie. Questions and perspectives, Glenn?
I think internally there's an opportunity for us to just be clear about the things that we want to improve here, as we discussed this morning, but then also, as we discussed this morning, I think externally we probably just not need to, we should be as modest as we sometimes are as an organisation about these results, because particularly in the employment market, we need to absolutely talk about being one of the 5 best NHS trusts in the entire country, which we should be very proud of, and hopefully that will allow us to to tackle some of those challenges we've already touched on in terms of reducing temporary labour costs, etc. So yeah, externally we've got a lot to shout about. Internally, we'll continue to focus on the things that we can improve.
Yeah, no, absolutely. And any other questions or perspectives to Gertie? Okay, so we'll move on then to the board committee on the minutes of the Clinical Governance Committee of the 8th of Feb. Anything you want to pull out on this, David?
Not really, other than I've put in my report, no.
Thank you. Any questions to David? So then on to any other business, team. Any other business, please raise a digital hand if you're a board director. Okay, thank you. So then on to questions from governors and members of the public. I'm conscious, we've had a few questions that I'm aware of. The first, if we could, and I think we've talked about it quite a lot, but could you just go first with Mary Malloy's question, please, Sarah?
Will do. So Mary understands that there's delays in patients receiving cancer care in the oncology department at Stratford Hospital, especially since Clive Irwin has left. Should Mary be concerned? Are the board concerned? If so, what is being done to improve the situation?
Okay, thank you, Mary, for that. Obviously, we have talked about that quite a lot today, Mary, in the public forum. Have we addressed or identified our own level of anxiety, Mary, to your satisfaction?
Yes, that's okay for now, Russell. Thank you.
Thank you, but we will fully understand if members of the public want to ask in other public forum on that issue in the future, but thank you for your question.
I'm sure the governors will be discussing it further in the future, Russell.
Super, thank you. And then I think Mike Flaxman asked a number of questions. Mike, it's maybe because they were quite long questions, which was great. But if you'd care to sort of summarise them for us one by one, that would be super. Thank you.
Okay, it's down to two questions actually, which are about capital schemes and came from the excellent familiarisation visits that I did with other governors to the 3 hospitals recently. I have to say the staff that showed us around were excellent, and we were very impressed with what we saw. It was all very good. The first was at Warwick Hospital, where I went around with John Egan, and it was really that we didn't seem to know very much about the way that staff and patients would access the building once the main entrance is demolished. And that seemed to be something which governors would be very interested in seeing some detail on when it's available. And I suspect options are being worked through, and probably Roger Lloyd with the Wayfinding Committee are looking at it as well. But it's something that was concerning because I couldn't really see where people would get into the hospital once the main entrance was demolished. And I did note today with some alarm that a £750,000 scheme for improving I think it was the front door, that may be the main entrance, is actually on the reserve list with no funds allocated to it. So perhaps that's the first question. I don't know whether Sophie can respond in terms of when an answer might be available.
Sophie, so I guess the two things. One is the capital on the front door. Secondly, the whole issue of how do we make sure patients and families know where they're going when we're knocking buildings around and moving stuff.
Yeah, and we know that over the next 18 months in particular on the Warwick side, right, we are going to have a severe amount of disruption to people. There is a specific work stream looking at this. I think we're working at such a speed, we've been quite focused on just trying to get the plan in place. We've now got that, and we've had planning approved. So I'm happy to bring that back or share that with you separately. We clearly will need to navigate people in, although shutting the door sometimes does feel like a good thing to do around ED. In terms of the front door, so I'll bring that back, but for assurance for you, we are absolutely looking at how we navigate around the site during the build, because it's not just the front door being demolished that will impact on it. We are doing the Salix funding as well, so severe amount of disruption that we will need to work through. In terms of the front door, that's not actually the main entrance, that's around some clinical services, and that's around going into an existing area, and that has been the an existing clinical area. It's only by working with Harkema really and her teams to see whether we can actually go into that area to do it, which is why it's on the reserve list, because we don't have a plan to do it. And I do think we need to be mindful this year in particular on Warwick Hospital site as to how much we can do, because we're doing the elective hub in itself is a significant development alongside the Salix funding. So I will bring that detail back to you in terms of the wayfinding.
Okay, super. So
Thanks very much.
we can do that clearly. Important as Mike is and governors are, the key people we want to keep briefed on where to go are our patients and their families. So that for me is the focus. And I know Adam's aware. I've had problems just being trying to direct people on our website to different parts of the hospital. It isn't easy. So the whole issue of navigation goes beyond the wayfinding to the way the website works and Google works. Mike, your second question?
Yeah, this just relates to Stratford and the community diagnostic hub. We've talked about it, our subgroup of Stratford governors, and we don't feel that we know enough about what's going on. And basically, we'd like to understand which diagnostic services are being provided in the scheme, how GPs and others might access the services directly, which relates to the operational policy, what the forecast impact is on diagnostic performance and the waiting list, etc., and how the scheme will fit into the existing buildings, if it does. So I guess there's a lot of questions around it, and it probably requires a fairly detailed response.
Yeah, that sounds like 5 questions to me, Mike.
Yes, sorry about that.
That's okay. So who wants to lead off on this? Sophie?
So in terms of the Community Diagnostic Centre, you'll know we have one there now, and I'm happy to follow up with governors on the services that we're running already at the Community Diagnostic Centre. We have got additional funding that we are looking to expand that CDC. We're currently in the options appraisal process. A paper's due to go to our management board at the end of the month. I believe I'm at governors this month, so I was planning to cover off what those options look like, so I can cover off the capital development there. In terms of the capacity planning, Suki in Harkema's team has done quite a robust piece of work around that. So I don't know if Harkema, you wanted to pick up anything on that. And GP access, I think, again, is sitting within Suki Ray's doing that within her team, but it is all happening.
Harkema, anything you'd like to add?
Yeah, there is a profile of activities. So Sophie, if I share that with you for you to go through as part of your governor update.
Yeah, that'd be great. Thank you.
I think, again, it partly goes back to the general point about making sure that our members of the public understand where they go for different stuff, and what the different parts of our property base provide in terms of services. I'm not sure from a comm side, and I hope I'm not being unfair on this, we're quite getting it right and as clear as we could do. And I think that's a flavour of what Mike is pointing to. Mike, thank you for your questions. Look forward to speaking to you soon. Are there any other questions from members of the public? Please raise a digital hand.
Russell, we did have another question from Roger Lloyd.
I apologise. Roger's not with us today, so would you care to read that out for us, please?
Thanks, Russell. So the Board Assurance Framework and Risk Quarterly Report has reference to the Chief Executive of Innovate stating that there's no risks to add to the BAF. There's no reference to Swift Clinical Services making the same statement. Have they added to the BAF, or should they be stated as adding nothing to the BAF? If it is appropriate for one subsidiary to do this, why not the other?
Okay, super, thank you. Roger, in absentia. Adam.
Yes, I think that's probably bad labelling on our part. So the Chief Executive Innovate report actually is digital risks to the trust. So I think we need to label that. If there are company risks, so if Innovate or CS have risks that impact on the trust, those risks would be on the relevant chief officer's risk register.
Okay, super. We'll have a word with the previous chief executive of the Innovate services on that one. Okay, any other questions from members of the public? Otherwise, I'll draw us to a close. Okay, thank you. I can't see any hands raised. Just to thank members of the public for joining us. Our next meeting is on the 6th of May, I believe, just checking my dates, which will be a 3 board meeting. So look forward to seeing you at that session. And in the meantime, take care, have a happy Easter, and enjoy the inclement weather. For board colleagues, I suggest we have a 10-minute break, grab a coffee, and see you again at 3:35. Take care.